Now, I think everybody's desire, I was going to say dream, perhaps that's a bit high, of learning to manipulate is that you're going to have a technique which somebody kind of staggers in like this, and you lay on and do something miraculous. Oh, yes, that feels, and they walk out like this. And when you listen to teachers and manipulators talk, they kind of give you these examples where this person came in like that and laid them out. And it might have happened about 3 or 4 times in their career. And they talk about this as if it's like an everyday occurrence. Now, it does happen to us, and we're glad when this happens. And sometimes, when we think it should happen, it doesn't happen. And we keep quiet about those, because it's a disappointment to us. But I think sometimes you can learn far more from your disappointments and from those things where you'd made this prediction, you did this technique, and it doesn't work. Why didn't it work? And that's where you have to go through a little bit of soul searching as to why it didn't happen. However, when we come to the thoracic spine, very often this is an area where these miracle things do occur. We have people that can't move back here, and you do the right thing to them, and they can now move again. And it has like a profound effect on how they're feeling because of this area. On the other hand, you can produce very bizarre effects in the thoracic spine. This has happened to me. Excuse me, I've got all these sweets in my mouth and nuts and things like this. And this will suddenly spill out and be all over the video. Okay, now we can continue. Sometimes quite bizarre things happen. You know, you get patients that actually get very activated by a treatment in the thoracic spine, very often with a mobilization, sometimes with a manipulation. You can get exactly the opposite happening, where a patient says, I don't know what happened the other day, but I just got up, I saw you at 9 o'clock, and I slept for the entire day. As if the whole of the system has kind of been closed down. Now, on courses, this occasionally happens. Not people going to sleep, but usually the other thing. It's happened to me several times where you'll look over and you'll see somebody who is obviously kind of distressed emotionally, perhaps crying or tears coming down their cheeks or something like this. The last time that I was in Germany, I kind of looked around the group, and there was a girl who was crying, and I thought, oh golly, hope it's nobody, because we got 2 in collars and all sorts, because they just had motor vehicle accidents but had come to the course because they didn't want to miss it. So I sort of saw this girl, and I sort of thought, oh golly, I hope she's not one of the motor vehicle types that's taken a collar off. And she wasn't, and I went over to her, and I sort of said, can you tell me, you know, what's happened to you? And we were doing the thoracic spine, and she said, I don't know. She said, I just feel so sad. She said, and I'm going to have to cry. So I said, well, that's fine. I said, what we'll do is go and have a coffee, and you will be here alone, and then we'll come back, and if you wish to continue with the class, just or rest for an hour, or not be here for an hour. I said, that will be fine. So we came back after about 20 minutes, because this was where we went somewhere else for the coffee in this particular establishment. When we came back, this girl was kind of, she'd dried her eyes, and she was still looking a little unhappy. And I said to her, you know, just privately, if you'd be prepared at some time today just to describe those symptoms and signs that you went to the group, and do it in German so it's no stress to you, and then, you know, somebody can tell me what you were talking about. And she did, and she described to the group this feeling of very great sadness that had come over her. Nobody had hurt her. There was nothing to do with that. She just said, I have to cry. And the next morning she came in, and I said, what happened? She said, I felt quite sad for the evening. She said, but today I feel so much better. She said, I feel loose, and I feel that, you know, a big pressure has been taken off my spine. So I don't know what this is. It's obviously something to do with the autonomic system. It's something to do with the flight and fight response, because what we've got here in the thoracic spine, particularly with a problem that's lasted a while, and these are quite common, is that a certain area of that thoracic spine is activated. There must be an activation of the autonomic system, the sympathetic part of the autonomic system. This is creating a state of flight and fight in those tissues, which is certainly not a state of healing. Those tissues can't heal when they're in this state. And then you come along and you perhaps for the first time cut down on the nociceptive input that's continuing in that area. And perhaps that relates to this sort of release. I don't know, this is purely speculative, but it's not unusual to find either an activation or a depression of the autonomic system. Now, I don't describe to all patients this might happen because it's fairly rare. But when you've seen it, it doesn't faze you. You just calmly get on with what you're doing and just say this happens in this area and just describe it in the terms that I've done. This is in a state of flight and fight, which we think about as being intense stress in this area, and now perhaps for the first time we've reduced that. And one of the things that you will do, if culturally it's acceptable, is perhaps to cry. And I think that's a good thing, you know, that we sort of recognize that those things happen. Now, in this system, and I don't particularly want to talk about this just right at this moment, Greg Grieve, and I will speak about it though in terms of about 7 or 8 particular syndromes that can be a little confusing sometimes. Greg Grieve gave a lecture in the IFOMP meeting in Cambridge, which he called the masqueraders. And these were various visceral things that happen within the area of the thoracic spine that mimic very closely thoracic spine musculoskeletal dysfunction. And this can be a little confusing to us sometimes. And sometimes we miss, very often we miss, what was going on. And Lewitt sort of speaks about this missing a diagnosis. He says that oftentimes when patients go to a specialist in musculoskeletal dysfunction and they find a musculoskeletal problem which they manipulate, and it wasn't that, and then they go and see a specialist 4 or 5 months later as they work their way through the system, and they spot what it is at this time, not cold like the musculoskeletal person was originally, but having had a whole lot of things that haven't worked, and so they're focusing a little bit more on, you know, perhaps a more limited set of possibilities. And he says it's very easy at that stage to pick up that this was a carcinoma or a thing, but he said there was nothing early on to even remotely suggest that's what it was. And even then we don't know necessarily that that was causing the pain at that time. So he said it's very easy in retrospect for other physicians to look at a patient and say, well, it was this and that was inappropriate, but at the time it perhaps was perfectly justifiable to interpret it in that particular way. And what we want to do is to accept that we'll make mistakes. Everybody makes mistakes, but we want built into the system sufficient safety that if our mistakes don't actually put the patient into any kind of danger, fracture bones, you know, do things that are totally inappropriate. I think I told you the other day about the lady with the lump, didn't I, on her head, that it so transpired that this thoracic pain that I thought was a musculoskeletal problem was actually probably a metastases, but I'd manipulated that woman and she hadn't had any disastrous effects from the manipulation. So even though it was inappropriate, still built into the system was some degree of safety. And I don't think there would have been if I'd have been jumping on her spine in a prone position. But going into this and just rocking gently and getting her to breathe and a little bit of a push like this was perfectly safe for her. It didn't work, but it was up and down. And as I said to you, this was the use of manual therapy, because I always feel quite confident with thoracic spines, most of them. 90% seem to clear up. Perhaps the other 10% I'm going to have to do a biomechanical analysis, which you're going to teach me in the next couple of hours. Okay, or perhaps not a couple of hours, but in the next day or so. All right? And perhaps those I should be looking at in a slightly different way. Perhaps they're just not treatable. Who knows? So we need to have built-in safety, and I think this is what we've been all trying to do. So, When we look at the thoracic spine, so we're not sort of spending too much time on the examination, because you've done a lot of this, I would say that with a manipulation of the thoracic spine, we have our mandatory examination again, like our mandatory minimum that we must do. We can't just lay down there crunch. Now that happens all over the world, I'm sure. Like a chiropractor I was talking about in my town, that's the busiest chiropractor in North America, who treats 150 patients a day. He works from 7:30 in the morning till 11 o'clock at night. Every day of the week, but Sunday, when he only works till 3 or 4 o'clock in the afternoon. And at 11 o'clock in the evening, that's when he does his house calls. Now, can you imagine anybody as sick as that? I mean, I've read several books. My wife keeps leaving them out in conspicuous places on workaholism. And I know I'm a bit like that. And I kind of ask myself the question all the time, what am I trying to justify doing this? To myself, or, you know, or whatever. But what is he trying to do? I mean, he's treating more than 3 times the amount of patients that I see in a day, and I am shattered after my little third. And when I tell you my numbers, you go, oh God, how can you do this? And here's a guy doing all these. There was one little story about this fellow that everybody loves him, and you know, he's gentle. I kind of think he's a bit ineffective myself, you know, the gentle, and a little bit of this, a little bit of that, a little bit of that. But at the end of the time, he always does the same thing to patients. One of my patients told me. He gets them on the shoulder like that, and he says, "You needed that." And I thought to myself, that's really good. I like that little statement. So in comes a patient. I did a good treatment. I said, geez, I feel a lot better. So I looked at them and I struck them on the shoulder like that. I said, you needed that. This guy looked at me and said, oh, you go and see Dr. Smith as well, do you? So I thought, right, I'm not using it. I've needed that again. Okay, so our minimal kind of acceptable examination, I think, prior to doing manipulation, and Diane's given you this much greater biomechanical analysis than this will give you, I'm certain. But this seems to work quite well for many of the problems that we're seeing. And we don't want to be doing a more advanced kind of examination on everybody if it's not necessary. We want to save the difficult stuff for the difficult patients and then concentrate on those. So this is what I would feel is a reasonable minimal examination to do. Well, how do we plug this in? Oh, okay, let's go. Thanks. And I think this is a minimal examination for mobilizing or for manipulation. I just work out how stiff they are, how reactive they are, as to whether I'll mobilize. I think we need to look at dural signs and cord compromise, first of all, because we're trying to get those, in this case, the dural signs, we'd have to be very careful with, and we'd only use distraction. With cord compromise, of course, these would be contraindicated. I've given you in your notes a classical article, which I think now needs to be upgraded somewhat, on thoracic disc. It's a wonderful article, one of the classical kind of articles that ever came out. It's in your handout. So we have dural signs. We're going to look for neck flexion, knee extension, and combining the two. Now, this isn't the slump test. I kind of don't like the term the slump test very much. I think the slump test for me is a fairly advanced stress procedure. I think that there are dural procedures we should use which are kind of like mild slump tests, if you like. Now, with the cord compromise, we should look at tendon reflexes. We should compare upper limb with lower limb, which is very useful. Look for the Babinski, look for clonus, and look for the superficial abdominal. Let's sort of leave that one out. And also ataxic gait. Those would be the signs of cord compromise. This is a thing that we looked at when we did the cervicothoracic junction, trying to exclude the cervical spine, because we need to treat the cervical spine. Having found that all of this is perfectly acceptable and we can go on, having found that the cervical spine is not causing us any major problems, then I think we can go down into the thoracic spine. We'll do our movements because we need to get the salient signs, and then we're just going into finding the level that we need to examine in detail. Now, I'm not going to be spending a lot of time on this because although it's incredibly important, and I think you should just go through it just once with your partner, this is stuff that you're always doing. So we now go into the passive oscillatory movement. And I'll just get Chris here. You can use any kind of movement for this, but this is the one I tend to use more than any other. Sit on there, yes, please. Okay, let me backtrack just a minute. In this particular case here, we were trying to exclude the cervical spine. We've also got another problem when we deal with the thoracic spine, and that's the ribs. Is it coming from the ribs when they do a movement? And you could make a little distinction, I think, between rib joint dysfunction and cervical joint and thoracic joint dysfunction by Chris is just doing his various movements. The chances are when he comes into extension, he's going to couple that with breathing in. And when he kind of does this, because it's part of our basic pattern of breathing, we'll tend to, it just comes along. You do this, you tend to breathe in. And so we could say to Chris, now, that's painful. Is it a rib joint breathing in kind of structure, or perhaps or a rib that's held in an expired position, an inspiratory restricted problem, or is it the movement of the rib, or is it the movement of the spine? I could simply ask him not to breathe for a minute, or I could place him in the flex position slightly, ask him not to extend, and then ask him to breathe in. Now, I know that this restricts the breathing pattern a little bit, and it might not be totally exclusive, but at least if he gets pain in the flex position where he didn't before, and he breathes in, and that increases the pain, which he didn't get before, then it would suggest we should be spending a bit of time on the rib mechanism, trying to analyze that. And so I try and get a bit of a focus as where am I going to spend my time? They've got 3 minutes with me, so where's it going to be spent best? All right? That's a little exaggeration, being as that's on time. Of course, we don't spend 3 minutes, but you still need to focus. And doing a lot of unnecessary work in a lot of areas, Cyriax used to sort of really be, let's just do the tests that tell us the information and not let's confuse ourselves with all kinds of superfluous tests. And I think now we've got so many tests with so many courses that sometimes you get totally lost, don't you? Are we going to be looking at, we've just done 3 weeks on muscle stretching and muscle analysis. How do we fit that into the 5 weeks that we did on manual therapy? And then the 7 weeks we did on trigger point stretching. How do you fit it all in? Well, what we've got to do is develop our own little synthesis and utilize these and put them into our little system. So I would try that. Now, the passive oscillatory movement that I would do would simply be this. I would get hold of Chris's shoulder like this, and all I'm going to do is just a little movement like this. I'm not getting near end range. I'm looking to see if there's some degree of sensitivity as I come down here that he could tell me about, or some degree of stiffness. That's all I'm looking for. Just thinking, right, I'd better start looking between those two areas there. And we'll come into a little bit of left rotation, and I'm just feeling on one vertebra moving above, and he's basically fairly stiff in this area. Then we've got another little stiff group here. So that's what I would do to sort of focus on perhaps a couple of areas that I need to look at in detail. I could at this stage, because it's quite convenient to, look at the effects of distraction, where I'm going to put his arms across here and just pull here. Does that relieve your pain, or does that increase it? If it increases it, I better be very careful. If it relieves it, it probably means manual therapy will be relatively successful. I come into compression, And I try and get fairly close, not just doing that with all the shoulder girdle, but trying to come through the front of the chest and the spine here and try and compress at whatever level we've decided is perhaps a little bit sort of dysfunctional. And when I did this, and perhaps he's complaining of pain in this area, so I can perhaps come down a little bit and compress fairly well just here rather than just pushing through here. If he'd shown any degree of dural signs, let's say he goes forward like this and that hurts, is it because that's an articular sign, or is it because I'm stretching an irritable dura? So I come back and I look at his legs. Does that hurt you? No, it doesn't. But next time, can you leave your legs up in the air, Chris? Just as and when I come down here, I can't get as far. Or when I come down now, it hurts more. Then I'm thinking very much of, here we've got a dural sign. When I look at my chord compromise, no signs there, but I'm thinking a little bit here. We basically better start thinking of distraction. However we tackle this, it's got to be distraction with that slight irritability of the dural sign. And that's how I try and keep myself in safe areas. When I look at the XXA, ale, dizzily steers, hurting legs tonight, watering places, okay, that's basically neck. But we look through that and we think to ourselves, X-ray, how old are you? Female, 60. Have you had any spinal X-rays? Are you on estrogen? Are you on calcium? Because there may have been some osteoporosis there. We get down to some of the others like S, steroids. Have you been on any anti-inflammatory medications, particularly steroids? Bladder and bowel, that sort of stuff comes out from that original thing. X, first thing, X-rays, but have you been in any trauma? You know, that list is quite useful for all areas of the body if you just sort of pick out the bits that are relevant for any particular area. And of course in this area, carcinomas, metastases is important, osteoporosis is important for whatever reason. Whether it just be postmenopausal or whether it be steroid-induced or something like that. So this is an area that is going to give us a great deal of pleasure to treat, but on the whole, we've got to sort of focus on when is it safe to do things. The last thing on the board here is lying on your front, multi-segmental reaction. I don't think this is an excluding test, because that woman that I saw didn't show up any reaction to this, and I always do it. Okay, which is to simply take the spine like this in its curve, and any push that I do on that curve will always be at right angles to the part of the curve I'm in. So I'm going to take the table down a little. This is what Alan Stoddard used to speak about. And I'm going to come up the spine from below, just pressing gently, take up the slack, little tiny overpressure, take up the slack, overpressure, overpressure, gradually just working up the spine at the right angles to the particular part of the curve. And he used to talk about multi-segmental spasm, as if the whole thing went into spasm as you did this slight pressure. That should never be ignored. Night pain was another thing, of course, on that list that we would never ignore. And in this area, night pain is often not so uncommon, and it seems as if it's related to congestion. But I think we've got to ask a few questions about how intolerable it is. Does it really sort of keep you awake? And if it does, I think we should be perhaps a little bit questioning, particularly if they've had any primary lesions that they know of anywhere. But certainly the breast and certainly the lung we should be thinking about. So that would, to me, be the sort of basic little run-in to looking at dysfunction. And then I've got my little group here that I'm going to look at. And now I can come into doing a little bit more of my rotary techniques, like this, and then come onto the other side and have a look at the motion. And see if I can sort out if there is a restriction of rotation. I can come into a sideline position here, Chris, please, for a second. Put your hands behind your neck. I can use my body here to basically just push back like this to look for an extension problem, as you know, or I can sort of close down a little bit with my arm around here and do for flexion. I don't usually test side flexion, and if I do, I would do it in sitting, because it's hard to do in lying. But I think if you are doing rotation, rotation is a much greater movement than side flexion in the thoracic spine. They're both coupled, so if one's missing, the other's going to be missing, and so I tend to do just rotation. And having done that, I'm now in a position to decide if I'm going to do a distraction equally, if I'm going to do a unilateral technique, and that's going to be based generally on, is the pain central and bilateral, or is it unilateral? I've got a real simple concept here. This is it. I'd probably be a bit ashamed to demonstrate this if Dan was here, going into all sorts of analysis. You know, you kind of wonder whether it's inadequate, but it works for me very well. I look forward to thoracic spines going in. If your receptionist says you're 8 patients behind, that's the bad news. But the good news is 6 of them are thoracic spines. Oh! Okay? So, this is the way that I would tackle that. Now, have you any worries with my conceptualization there? I think we've got to be safe as far as the medical conditions are concerned. I think we've got to be safe as far as the biomechanical conditions are concerned, particularly the disc. There was a very good article in the Spine fairly recently by a fellow in Colorado that did an experimental study on thoracic spinal dysfunction in the sheep or something. That's perhaps why I didn't read it. But then about 6 months later, when Wayne Gretzky gets his back problem, his thoracic disc problem, which is treated under the advice of White from San Francisco, who said, don't go near him with surgery unless he's got all of those ataxic gait, Babinski, hyperreflexia, you know, the cord compromise signs. Go with a very, very specific, heavy program of exercise. And actually, it was based on the guy that did the work on the sheep. You know, and they're quoting him. Now I can't find that particular spine, so I've had to write to this guy for a copy of his sheep article. Okay, and I'm waiting for it to arrive to see what the significance of all this is. But distraction has obviously got to be part of what we do because it doesn't threaten the disc. And even though the disc